Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with Crohn's disease and ulcerative colitis? Find out more right now. My guest this evening is Dr. Nikiya Asamoah, a practicing gastroenterologist at MedStar Washington Hospital Center. Nikki, welcome to Housecall.
Oh, thanks for having me.
My pleasure. So briefly tell our viewers about your professional background.
Okay, so as you said, I'm a practicing gastroenterologist at Washington Hospital Center. I joined just a few months ago the practice, and I'm happy to be here. I came from Chicago. I did my my medical training at the Medical College of Wisconsin, and then my GI training at Loyola University Medical Center in Chicago. I stayed on as faculty after my GI fellowship, and then transitioned here due to family reasons, and now I'm here at Hospital Center. I am the IBD director, so I'm starting a program at Washington Hospital Center for Inflammatory Bowel Disease, and I will serve as an assistant professor at Georgetown for the GI Gastroenterology Fellowship. So that application is pending, but I'm happy to be here and seeing our IBD patients here at Hospital Center in the time during this.
Terrific. Welcome to the community.
Yeah, thank you. Thank you.
So briefly tell our viewers, what exactly is the thought at this point in time about the cause of what's called inflammatory bowel disease, IBD?
So inflammatory bowel disease, as you know, is a chronic autoimmune condition where you have intestinal inflammation, which leads to bowel symptoms. Right now, we don't know the actual cause, but we think there are a few factors that play a role. One is genetics. Most people who develop it have some genetic predisposition, but there are environmental factors that trigger your immune system to kind of go to respond inappropriately. So the combination of those three things is what we think plays a role in the development of inflammatory bowel disease.
Now, I understand that there's two categories of inflammatory bowel disease.
Yeah.
Crohn's disease and ulcerative colitis, as I said in the opening. Share with our viewers the differences and similarities between those two conditions.
So they're very similar with a few slight differences. They both are characterized by inflammation of the intestines. The difference between ulcerative colitis is that ulcerative colitis has inflammation that's limited to the colon. Whereas Crohn's disease, you can have inflammation throughout the entire gastrointestinal tract, including the stomach and small intestine. And Crohn's in particular often presents with inflammation in the small bowel. The other difference is that Crohn's disease can cause blockages, or what we call strictures, or inter-bowel connections called fistulas, which we typically do not see in ulcerative colitis.
If somebody has ulcerative colitis and they don't respond to medical therapy and they need to have their colon removed, does that cure the condition?
For ulcerative colitis, we think that removing the colon does technically cure you of the inflammation from ulcerative colitis. The unfortunate thing is there is something, the type of surgery that these patients will have is called ileoanal pouch, or J pouch is the most common procedure that we see when we remove the colon, where you could create a pouch from the small intestine that serves functionally as a rectum. The thing that we see in ulcerative colitis when you create this J pouch is that some people do get inflammation of that pouch. and it's called pouchitis. They may have urgency and more frequent bowel movements similar to the symptoms that they had with ulcerative colitis. But we don't think this is disease recurrence. We think this is just abnormalities of that pouch. Not everyone develops pouchitis, but when you do, typically there are treatments, not necessarily immunosuppressants that we use.
If somebody has Crohn's disease and they're not responding to medical therapy and they need to have surgery, are they cured of their Crohn's disease?
No, unfortunately not. As I said, Crohn's disease can present anywhere from the stomach all the way down to the anus, or the mouth to the anus. And so typically for Crohn's disease, if someone has surgery, we try to remove the most affected part. So the part that's most inflamed, we try to remove that, but the rest of the colon is, or the intestines are still susceptible to inflammation, unfortunately.
Now let's educate our viewers in terms of the potential alphabet confusion. There are many viewers who are watching this evening and have a condition called IBS, irritable bowel syndrome. Is that to be confused with IBD, inflammatory bowel disease?
These are two very different diseases. Irritable bowel syndrome is a functional bowel condition characterized by changes in bowel habits. Some people have diarrhea, some people have constipation, and they have these fluctuations between those two, or even just normal bowels. And that's often associated with mild or moderate abdominal pain. The key difference is if you do a colonoscopy for someone with irritable bowel syndrome, the colon typically looks normal. If you did CT imaging or any radiographic imaging, and for a patient with irritable bowel syndrome, their bowels look normal on that imaging. Whereas in inflammatory bowel disease, as we said, you actually see inflammation, ulcers, redness on both, radiographic imaging and colonoscopy or endoscopy.
How common is ulcerative colitis and Crohn's disease?
So according to the most recent CDC data, about 3.1 million people, Americans, I should say, are living with inflammatory bowel disease, and that's about 1.3% of the population. This number continues to rise each year, so we're seeing more and more patients with this condition.
And what are some of the risk factors for IBD? You mentioned genetics, but are there any other risk factors?
Yeah, so genetics we think is a key player. There are other things that can trigger. So as I said, environmental exposure. So exposure to antibiotics, especially at a young age, we think that contributes. People who take a lot of non-steroidal anti-inflammatory drugs, so ibuprofen, Aleve, naproxen, they may be a little bit higher risk of developing inflammatory bowel disease. People who smoke cigarettes are at high risk of Crohn's disease and Crohn's disease complications, though that seems to be, smoking seems to be more protective for ulcerative colitis. So there are lots of environmental triggers, but we think that these people are already predisposed to develop the condition.
As you know, there have been some interesting observations about Helicobacter pylori and IBD. Yes. Share with our viewers what exactly is that bacteria and how it potentially can interface with IBD risk.
So H. pylori is a bacteria that can commonly be found in the stomach. It can cause ulcers, irritation. Some people just have some mild symptoms of upset stomach, nausea, vomiting. We think that we develop it in our communities. It's hard to say when people are exposed because some people can live with it for many, many years without symptoms. Typically, we test for it when we do any upper endoscopy for anyone with gastrointestinal symptoms. But H. pylori seems to not be correlated with inflammatory bowel disease necessarily. So maybe protective in some way.
So if you've had it, you're less likely to get it?
That's the thought. It's not always correlated with it.
So how exactly is inflammatory bowel disease, meaning ulcerative colitis and Crohn's disease, diagnosed?
So there are a couple of blood tests that we do, stool tests, as well as radiographic imaging that can help with the diagnosis. However, in order to definitively diagnose, you need a colonoscopy and possibly an upper endoscopy to diagnose the condition. So that's our mainstay of diagnosing. But again, we use CT imaging, blood tests, even stool tests to help with the diagnosis.
For many years, there was an interest in developing what are called IBD serologies, antibody panels to screen for Crohn's disease and ulcerative colitis. A lot of that research was actually done in Chicago. So what are your thoughts at this point about the utility of using these blood test panels to screen for ulcerative colitis, Crohn's disease, and even make predictions about what the outlook prognostically will be?
I think we have some work to do on these blood tests. There are some blood tests that help to differentiate the two conditions when you have a diagnosis. But unfortunately, the blood test alone won't diagnose the condition. I actually don't usually use those blood tests because I haven't found them to be as accurate as, say, a colonoscopy and even stool testing. But in one instance, I often talk to my residents and fellows about using it. It's in the case where you have someone who's admitted to the hospital with severe colitis, where the inflammation remains just in their colon, and they potentially need surgery. And so the important decision to make at that time is whether or not you should remove the entire colon and do this procedure called the J pouch, as I mentioned earlier. That's what you would do for ulcerative colitis, but you wouldn't want to do that in someone who has Crohn's disease. And so in that instance, if that person had a blood test that was showed more positive for Crohn's versus ulcerative colitis, that would definitely help us to determine which surgical procedure this patient should have. So that's the one time where I think that blood test may be helpful, but I don't routinely order it on my patients.
Sure. So once you've diagnosed Crohn's disease or ulcerative colitis, there is, as you well know, a tiered approach to treatment opportunities. Tell our viewers what is the spectrum of treatment available for mild, moderate, and severe ulcerative colitis, and similarly, what some people now call the reverse pyramid for Crohn's disease.
Yeah, so there are lots of medications that are on the market and new ones coming every year or two for management of ulcerative colitis and Crohn's disease. For mild ulcerative colitis, there are pill medications. These types of medications are called mesalamine. They work by decreasing the inflammation in the lining of the colon. These medications are not FDA approved for Crohn's disease per se, but some people tend to use them for people who have mild Crohn's disease as well. The other medications that we have, there are a range of medications that range from medications that a patient can inject themselves every 2 weeks or even every 8 weeks. There are medications that you get by IV infusion, typically at an infusion center. All of these medications work in different ways to suppress parts of your immune system, because as we said, the cause of inflammatory bowel disease is having an abnormal immune system response. So you want to suppress the immune system so that you're not having this abnormal response. So lots of drugs on the market for them. You may see commercials for them ranging from Remicade and Humira, which have been around for 20 plus years, to newer ones on the market, including Entyvio, Stelara. These are all brand names of drugs that we use on a day-to-day basis, and most of them are FDA approved for both Crohn's and ulcerative colitis.
We're going to pause briefly for a public service announcement. More with my guest, Dr. Nikiya Asamoah. We'll be right back.
If I could be you, and you could be me for just 1 hour, walk a mile in my shoes, walk a mile in my shoes.
We're back. My guest this evening is Dr. Nikiya Asamoah, gastroenterologist, MedStar Washington Hospital Center, and the topic at hand is ulcerative colitis and Crohn's disease. Nikki, when we paused for the break, we were discussing the many different treatment options for Crohn's disease and ulcerative colitis. So when you give this therapy, is it a one-time thing? Is the patient cured, or are they committed to lifelong treatment?
Unfortunately, there is no cure for IBD at this time. So we use our therapies to suppress bowel inflammation. So it's not a one-time thing. Most patients are on the medications lifelong. We tell them to anticipate being on a medication for your bowel disease for the rest of your life. Again, when we use these medications, the goal is to suppress the inflammation. And if we are able to do that, people are able to live their lives the way they normally would, whether it's conception, running marathons, traveling. There's really no limitation. The goal, though, is to have complete remission, clinical and endoscopic, meaning when we look at your colon, the colon does not have active inflammation.
Given that these medications, as elegant as they are, do provide targeted suppression of the immune system to allow for benefit for the patient, how safe are they if they're going to be suppressing the immunity?
So the medications do come with risk. These risks are relatively low, but things that we monitor for are infections. Some of the medications, because they are suppressing your immune system, increase your risk of infection. The other risks that may be associated with these medications are certain types of skin cancers and even blood cell cancers. The likelihood of these adverse reactions are very low, and the potential benefit of these drugs outweigh the potential risk, especially for people with severe inflammation, but they're not without risk. And so people who are on these medications have to have close follow-up with their gastroenterologist or IBD specialist just to keep an eye on their routine labs, make sure they're up to date on their vaccinations, things to prevent and monitor for possible side effects.
Many patients, I'm sure yours do, I know mine do, is they often ask, what could I do from a dietary standpoint? What are your thoughts about the so-called anti-inflammatory diet?
So that is a very common question. There's a lot of research on what diets have may be effective in decreasing inflammation. At this time, there isn't a specific diet that is known to decrease the inflammation in your intestines. There is a spice, turmeric, curcumin, that has been shown to have mild anti-inflammatory properties. So patients with very, very mild ulcerative colitis who take turmeric or curcumin supplements might have some benefit. But unfortunately, there's no specific diet or specific food that we have found that will cure or improve the inflammation otherwise. We do recommend that patients who have active inflammation in their bowels stay on a diet called a low residue diet. It's typically a low fiber diet that consists of mostly lean meats, ground meats even. If you eat any vegetables, they should be steamed and very soft, and stay away from wheat and fiber. These are the things that we typically encourage our patients to eat. But unfortunately, in patients who have active inflammatory bowel disease, these foods can cause more bowel symptoms. It doesn't change the actual inflammation, it's just more symptoms. So people feel more uncomfortable, more diarrhea, more pain when they have active inflammation.
The next question you and I get with our IBD patients is, doctor, besides a healthy anti-inflammatory diet, what are your thoughts about probiotics, healthy bacteria? So what are your thoughts about probiotics, which go in and out of vogue for IBD?
I most of the time probiotics don't hurt. In certain patients, we actually recommend them. So I mentioned this condition called pouchitis with people who have a J pouch anatomy who've had this prior surgery for ulcerative colitis. There's been shown to be benefit from taking probiotics to prevent pouchitis. So in those patients, actually, probiotics are helpful. I'll say that one of the difficult things about probiotics is that they're not regulated. They're a supplement. And so there are lots of probiotics on the market and they haven't all been tested or approved, or and we haven't figured out the best dosing for all of the different probiotics. So it makes it a little bit difficult to recommend probiotics for patients. Overall, we haven't seen that they cause any harm, but for some people, they may not be helpful.
What happens if you have a patient who's afraid of taking medicine, especially biologics, and they say, well, I'll just live with it? What is their outlook?
I think that's one of my harder patients to talk to, because I understand thinking about being on a medication lifelong is difficult. But there are lots of complications of inflammatory bowel disease that we try to prevent. One, progression of disease. Often some people may have worsening inflammation to the point that they're having several bowel movements a day or become anemic because they're having so much rectal bleeding. In Crohn's disease, you can have people develop abscesses, both inside of their abdomen and in their perianal area. You can develop fistulae, which are connections between the bowels, strictures or blockages in the intestines. And the worst part of all of it is the longer you have the condition and the longer you have active disease, there's a higher risk of colon cancer. So for my patients, I try to talk about these risks, not to scare anyone, but just to say, you know, these medications have been shown to be safe and effective at preventing these complications. And our goal is to prevent worsening of the disease.
You mentioned an important topic, which is colon cancer risk in patients with both ulcerative colitis and Crohn's colitis. Explain to our viewers what kind of follow-up colonoscopy surveillance they need to be protected.
So we've seen, or the data has shown that after about 8 years of diagnosis, the risk of colon cancer increases above that of the average person in someone who has inflammatory bowel disease. So typically, at least after 8 years, you should expect to have a colonoscopy every 1 to 3 years. Now, your risk of colon cancer may increase depending on if you have active disease, if you have a family member who has colon cancer, if you've had precancerous polyps or adenomatous polyps in your own colon. Those are higher risks of developing colon cancer. So those people may expect to be having colonoscopies every 1 year, but the current guidelines recommend every 1 to 3 years, depending on your risk after about 8 years of diagnosis.
We may have patients, young women of childbearing age, who are worried, will I be able to conceive? Will I be able to go to term and have a normal pregnancy? What do you say to those young ladies?
Absolutely. Let's keep your bowels under good control. So patients who have active inflammation may be at risk for worsening pregnancy outcomes, specifically preterm labor is one of the higher risk, and low birth weight may be associated with it as well. But people who have their disease under control, who are on their medications, can have normal pregnancies, conceive normally, and have normal deliveries, and the babies do fine in the post-pregnancy follow-up. So there's a lot of data that we have collected for patients who have inflammatory bowel disease with excellent pregnancy outcomes as long as your disease is well controlled.
which circles back to the question we all get. If someone's doing well on their therapy and they want to have a child, would you prefer they stay on their medicine, keep their IBD in control, and go on to pregnancy and delivery? Or would you prefer that they stop their medicine, take their chance with their IBD, and proceed with the pregnancy?
So I'll say often when people flare off of medications, or even patients who present, they often present sometime in their second trimester of pregnancy. So we recommend that you stay on your medications. Certain medications should not be taken during pregnancy. And so that's why it's important to have a close relationship with your inflammatory bowel disease specialist or your gastroenterologist to talk about any medications that may be a little bit higher risk. But our goal is to keep things under control during your entire pregnancy. So staying on your medications as long as they haven't been associated with risk is definitely what we recommend.
Now, these elegant immune suppressive agents are effective, but they're also expensive. Are they covered by insurance for the most part?
Yeah, for the most part, they are. Insurances cover the medications. Your insurance may have a preferred medication. Say, for instance, they want you to take Remicade instead of Humira, or Stelara instead of Entyvio. That's just insurance dependent, but they cover most of the medications that are approved, that are FDA approved for inflammatory bowel disease. And in some cases, the pharmaceutical companies will help out patients who don't have complete insurance coverage and give supplements and coupons so that we can treat these patients appropriately.
Now, given the recent pandemic, there's been a lot of question about the COVID vaccine. Is it safe to take if you're on these immune suppressive agents?
Absolutely. So as I said, a lot of these medications may be associated with increased risk of infection. So we recommend for our patients to have routine vaccinations, including influenza and pneumonia vaccine, as well as the COVID-19 vaccine. There are a few vaccinations that we tell people if they are immunosuppressed that we want them to avoid. And these are live vaccines, including the MMR, varicella vaccines. So those are the only ones, live vaccines, that we try to avoid. Otherwise, COVID-19 and all the others we strongly recommend, just because you are immunosuppressed. It's not to say that these medications will cause you to get COVID-19. It's just that if you were to develop COVID-19 or influenza or any other pneumonia, any other infection, your body may have a harder time fighting this off, or you may get a little bit sicker than someone who is not immunosuppressed.
Very briefly, if our viewers have any questions, how can they reach you?
Oh, my office. So they can go to our MedStar Washington Hospital website, or they can call our office. 202-877-7108 is our hospital office, our Washington Hospital Center gastroenterology office number. If they need to find an IBD specialist in the DC area, I am available. And anytime they have questions, please reach out.
Thank you so much for an informative interview.
Thank you for having me.
My pleasure, my friend. Welcome to the community.
Thank you.
My thanks to Dr. Asamoah. My thanks to my terrific team at the station. And my thanks to you, the viewer, for welcoming us this evening to your home. If you have any questions or suggestions for future programming, you can reach me at my email address listed on the bottom of the screen. As for our next show, it's going to be a fascinating program. It's going to be an update on cardiac surgery, including the new robotic approach. It's going to be a fascinating show. See you then next time for another edition of Housecall. Good evening.